Welcome to our conversation, AI-enabled compassionate end-of-life care. In this episode, we look at a fantastic prognostication tool that researchers have developed to accurately predict mortality risk in older adults, as well as their life expectancy, to inform palliative care decisions. Amy Hsu, a scientist based at the Bruyère Research Institute in Ottawa, and Peter Tanuseputro, a family physician and also a scientist at Bruyère, discuss the RESPECT calculator and how it can be used to start important discussions about end-of-life care.
Hello, and welcome to this conversation about palliative care and how we can enable compassionate care using technology and artificial intelligence. I'm Dr. Amy Hsu. I'm a scientist based at the Bruyère Research Institute in Ottawa and a faculty member in the Department of Family Medicine in Ottawa. I also hold the University of Ottawa Brain and Mind Research Institute Chair in Primary Healthcare Dementia Research. And with me today is Dr. Peter Tanuseputro. Peter, would you like to introduce yourself?
Yeah, thanks, Amy. Hello, everyone. My name is Peter Tanuseputro. I'm a public health physician by training, but also a family physician. I practice clinically in office doing family practice, and I do home visits for my dying patients. I do quite a bit of care in people's homes, quite a rewarding part of my practice. And just like Amy, I'm a scientist at the Bruyère Research Institute and at the Ottawa Hospital Research Institute. And we do a lot of research trying to improve the care that's being delivered to people who are near the end of life. Every good story needs an origin story, right, Amy? So I think, my origin story was in coming to Ottawa from Toronto. I did all my training in Toronto. I always tell Amy that 16 years I paid tuition at the University of Toronto, and all 16 years of it was worth it, I think. But Ottawa drew me in, and part of the reason was Bruyère and Bruyère Research Institute, and the fact that it had a real good focus on end of life and palliative care. And that was something that I was really compassionate about and passionate about. And to this day, I think both Amy and I are quite passionate about that.
Yeah. And Peter, I think we're maybe the odd ducks in this respect. There's this well-known quote that I often mention in my presentation, which has been attributed to Mark Twain. So there are two certainties in life that we know. These are death and taxes. And people often view these as subjects to avoid at all costs at dinner table. So these are not conversations that people have on a daily basis. But of course, we're different because we're so immersed in this field and so passionate about palliative care. So I really hope that our conversation today will help prompt some of the listeners to normalize the discussion of these topics about palliative and end-of-life care. Because we know that most people in Western countries like Canada die from progressive and predictable diseases. So in fact, in Canada, the three leading causes of death in our population have been cancer, heart disease, and stroke. And these account for over 50% of all deaths. So other leading causes of death, including dementia, chronic respiratory diseases, many of these chronic diseases share the same signs and symptoms of decline. So this idea of senescence, right, is common across these diseases, and they are predictable. They have predictable signs of physical deterioration, declines in cognitive function, as well as increased need for assistance. But despite the fact that most of these deaths are predictable, many Canadians at the end of life do not receive adequate home-based support or palliative care. And Peter, of course, you've led a lot of research in this area. And I was wondering if you can maybe speak to this a little bit more.
Sure, Amy. And yeah, taking a step back, I agree. We live in a society, Canada is thought about as a death-denying society, so that we live in a society that doesn't want to talk about death and dying. I think both of us recognize that that's not helpful. When we don't talk about death and dying, it sneaks up on us and we're not prepared. And both Amy and I, do research to open up those conversations, shine light to what's actually happening and shine a light to the deficiencies in the healthcare that we deliver to people who are dying. And, I think our journey sort of began by exploring, why are we doing this? Why do we need to improve care? And what is the current state of care? And, our journey began about 5-6 years ago when we were essentially the first researchers to show that across Canada, only 1 in 2 people will end up getting any palliative care. So palliative care in your doctor's office, palliative care in the hospital, palliative care in the emergency room, only 1 in 5 or 1 in 2 will get that care. And what's even more staggering is that when we looked at that care and we looked at where that care was being delivered, a lot of that care was not delivered in people's homes, right? So when people die or are getting closer to death, we all kind of know that, your body kind of shuts down slowly. Shutting down makes it harder and harder for you to go out of your house and visit your doctors. And obviously no one wants to end up in the hospital. But in the end of life, in Canada, we're still only delivering care again to 1 in 2. And the majority of that care is happening in hospitals. So, Amy, I think we both have done studies that showed that only 1 in people will get a visit in the last year of life. And only 1 in 5 will get home care in their home in that last year of life. And why is that? I think one of the reasons we think that that's the case is what you brought up, that people don't like to talk about death and dying. And it's not just people. I think the biggest culprits, I'm a doctor, I'm a family physician, and I honestly think the biggest culprits are doctors. I think we need to do something about that culture, right, Amy? And we need to try to open up those conversations among patients and families and caregivers.
And Peter, I think the other really important thing to highlight is we have ample evidence suggesting how important and how impactful it is to receive palliative care. So, for example, I know in our research where we looked at the impact of physician home visits, with every increase in a visit that a patient receives in their home, it actually reduces the amount of time or their frequency of being hospitalized at the end of life.
Yeah, that's very true. Exactly. And there's a less of a chance that you'll die in hospital, right? I think both of us are in agreement, and everyone is in agreement that no one really wants to go to the hospital at any time, but especially when you're dying. Most of us, when we think about death and dying, we want to be at home. We want to be surrounded by the family. We want to have that time to really, celebrate life. And when I visit my patients, obviously that could be quite scary and produce anxiety. But, a lot of people come to this point where they celebrate life and they celebrate what's been done in their life, and they celebrate with the families and loved ones that are around them. To do that, we really need to be where we want to be, at home. In the hospitals, especially during COVID, right? It was a bit of a disaster, right? People couldn't visit patients in hospitals or in these complex continuum care or even palliative care units. And I think one of the things that we recognize, Amy, is that you really need to anticipate and really, really know when death is coming so that we can prepare and provide that palliative care at the end of life. And I think Amy and I, we went down this journey saying that, well, in Canada, we have this death denying society. Can we do something about it? Both Amy and I work with big data, and maybe we can talk about that, right? The opportunity that lies on our feet.
Peter, you're right. I think it's not just the fact that we avoid these topics. We avoid talking about death and palliative care until we're confronted with the situation where we're caring for a family member, a relative, or a loved one who is declining and approaching the end of life. But the other challenge is that it's very difficult to prognosticate when the person might need palliative and end-of-life care. So without the capacity to prognosticate, it makes it very difficult for us to actually plan and provide adequate support for people at the end of life. And that's why Peter and I have, using population level data, have developed a risk algorithm called RESPECT. So RESPECT stands for Risk Evaluation for Support Predictions for Elder Life in the Community tool. It's a mortality risk communication tool that accurately predicts an older adult's 6-month mortality risk as well as their life expectancy. And the intention behind developing this algorithm is to inform decision-making regarding the initiation of palliative end-of-life care. So using large administrative data, population-level data, we were able to not only identify the predictors for mortality, but also to look at the survival once the prediction is made. And RESPECT as a tool was co-designed with patients and caregivers. We work closely with our patient partners to help to inform when they might actually be declining and approaching the end of life by estimating their survival in days and weeks and months. These are metrics that have been shown in research to be patient-oriented and meaningful for care planning. So RESPECT actually has been piloted in the Windsor-Essex County. We work closely with the compassionate care community there. It's a community-based grassroots organization, a coalition essentially of service provider in Windsor-Essex. They brought together individuals who are involved in healthcare, in community care, as well as other services that are provided to really support aging in the community, aging at home. And we work with them, and RESPECT was one of the tools that was used to assess frailty and the need for additional form of support. And this, we found with our pilot that this not only enabled providers to identify individuals who might need more supports in the community, but also those who could benefit from referral to palliative care services. And with the funding that our research team has received from AMS and OSSU for Scale and Spread, we have now built on the findings from our pilot to scale up. So Respect is now being implemented in home care program in the Ottawa Champlain region. And we're also starting to use Respect in several long-term care homes across the province.
I think that's great. And I think we have been expanding, and AMS was so fundamental in starting that up and getting the patient voice, because death and dying, again, can be scary. And we need to be sure, right, Amy, that we are giving people information that they want and in a way that's usable. And so far, the overwhelming feedback that we've gotten is that, yes, people do want to know. And often it's not just patients, right? It's caregivers, it's loved ones, people who have to care for these individuals, people who have to decide whether they should ask family members from out west or out east to come visit. And a lot of that is based on prognosis. The really, really fundamental thing here that we brought up is that, it's really powered by this population-based big data. And what people don't realize is that when people decline, so when they're in long-term care or when they're receiving home care, they get lots and lots of assessments. So people who are getting home care can attest to this, that you need services, you can be asked a whole host of questions, over 300 questions about who you are and what your needs are. And it builds these predictive models, mathematical equations, essentially, that says if you have X, Y, or Z, this is how long you're going to live. And the experience of people just like you across Ontario is that if you have X, Y, and Z, you have a certain life expectancy. And that's really powerful, right? Because as a clinician, sure, in some cases, it's, not that difficult to assess how long a person has to live, especially for, diseases like cancer. But for other conditions like dementia, it's a bit trickier, right? Or multimorbidity, like people with COPD or heart failure, renal failure, it's a bit more difficult. And I think what the power of Respect is that you don't have to guess as a clinician. And as a patient, you don't have to guess, right? It'll tell you just because, it'll tell you for people just like you, what is that experience going to be like? And what's that prognosis going to be?
So I think for our research team, when we think about compassionate care, a lot of it is about personalizing care, about empathizing with the patients and the caregiver to recognize their unique experience and their journey as a person declining and approaching the end of life. Peter, you and I have so many personal stories that we could share, right, with regards to how we've encountered or how we have experienced palliative end-of-life care in our personal lives. And one of those stories is, of course, one of our master's students on our team, Michael, who was instrumental in actually building a machine learning algorithm to improve the model performance of our current Respect algorithm. And unfortunately, he was diagnosed with cancer as he was completing his master's thesis. But I think his involvement in this research has helped him to think about how he wants his own end-of-life care, his own palliative care to look at. And we're very fortunate that in the Champlain region, we have an excellent palliative home care program. And Michael was just 29 at the time that he died. And he was able to receive palliative care at home, surrounded by family members, surrounded by friends. And even during COVID, we were able to visit him at home, which otherwise wouldn't have been possible if he was hospitalized. But because of his involvement in this work, he recognized the value of palliative home care, and he continued to be an advocate for that, I think not only through his thesis, but also through his life. And I like to bring up these stories because we know how important it is to ensure that people who want to receive this type of care can receive them. And prognostication is one of the first steps in identifying this need in our population.
Exactly, Amy. And none of that would have happened if someone in the hospital didn't say, Michael, I think you are approaching that phase of your life where palliative care should be discussed, right? I think as humans, we want to put on blinders and want to say that everything is going to be okay, or that we're going to try everything to lengthen your life. But the reality is that there are cases and there are times in people's life where quality of life should be focused on, right? Where quality of life is just as important as length of life. And without that prognosis, none of that would have happened. He could have stayed in hospital, continued to receive aggressive interventions. But no, someone recognized on his care team that it's a time to discuss how you want to live the rest of your life. And I think that's very, very crucial for people. So a good death is part of a good life lived. And it really is. To have a really good life, I think it's essential that we have a good death. And I think that's the journey that Michael went on. Very tragic, right? I think you and I, were really hit by it, not only because, he was such a lovely person, but he was our friend, right? And he worked on the exact tools that would help a lot of other people, realize so that people can, again, focus on having a good death.
And to empower patients and their caregivers' decision-making, in addition to our implementation in the home and community care setting, also in long-term care homes, we have built this web-based calculator based on the RESPECT algorithm. And it's implemented on our research team's website called projectbiglife.ca. And since the launch of our calculator, we have actually had over 700,000 calculations performed through our website. And we hope that this is one of the ways that we can move this conversation forward and enable individuals to not only advocate for their care, but also to have open conversations with their providers about the type of supports that they might need as they decline in health and approach the end of life. So again, you can find out more about the RESPECT calculator on projectbiglife.ca.
Does your work help answer the question, how can digital technology and artificial intelligence change the healthcare we provide? Go to amshealthcare.ca for more information on research funding programs and a wealth of resources on how compassion and technology is changing the healthcare of today and tomorrow. Now back to our conversation.
Now, Peter, of course, we're hoping that RESPECT is not limited to Ontario. So maybe you can kind of share some of our team's vision for how this will scale and spread beyond Ontario and how we could change the landscape for palliative care in the future.
I think we talked about the data that really drives RESPECT. That data came from Ontario data, from Ontarians who receive home care. One of the focus of our teams is don't only apply that algorithm to people receiving that care, but apply it so that anyone can use it, right? And that website, we should have mentioned it earlier, Amy. I hope people have a chance to go through it. Essentially, we created it to be people-friendly to the general layman. Clinicians need this information, but we think that patients need this information too. And to be honest, it's been somewhat contentious, again, because many clinicians or many people don't like to talk about death and dying. And ideally, you do RESPECT and you go through the website with a clinician sitting beside you, telling you and guiding you about what it means. But in reality is that if we leave it to the hands of the busy clinician, we're not going to get this done. We need the involvement of not just clinicians, but we need people to buy in. We need people to talk about death and dying. And most of those conversations don't happen when you're in the doctor's office. Most of those conversations happen when you're at home. What's really fascinating, right, Amy, is that when we build these tools and we put it on the web and people interact with it and use it, they're surprised at what actually impacts their life expectancy. Chronic diseases like heart disease or diabetes or COPD and multimorbidities or having more than one, multiple diseases what really impacts your survival and your life expectancy. It's not diseases that you're dying of, but it's your function. Bathe yourself, eat for yourself, dress yourself, do the things that are really essential to surviving and to actually living a good life.
So Peter, I think the other thing about Project Big Life and talking about the power of big data and population level data is that Project Big Life, we have the RESPECT calculator, which helps to think about care planning, but we also actually have a number of other calculators that help people think about how to age well and thinking about healthy aging. So on Project Big Life, we have calculators that help to estimate your risk for dementia, for example, and thinking about the risk factor that can enable healthy aging. So it's not just thinking about the service that you might need, but how do we age well in the community? So these are some of the ways that I think as a research team, we're thinking about providing personalized compassion care using technology and artificial intelligence. So building on the AMS funding, our team has actually been really successful in gaining additional research dollars to help with the scale and spread of our technology. So over the past 2 years, we received over $2.1 million in funding from CIHR to support our implementation and evaluation in a home and community care setting, as well as in long-term care, with the ultimate vision that this funding will help us to actually bridge that connection, that continuum of care that's provided to people in the community. And even when they transition to long-term care, we're hoping that information that's generated from Respect can actually travel with them from the home care assessment into long-term care.
Yeah, that's wonderful, Amy. And we should also mention that we received about $500,000 more to continue to improve Respect, right? And non-institutional settings, like in long-term care or hospitals, but to do it in people's homes. We're not done yet. We're not only looking at survival, for example, but we're looking at other things that matter to people. How many days will they spend at home when they're dying? How long people have left to live? And what Respect will expand into is this idea of looking at other end-of-life outcomes that might be more helpful and might align with what people want.
One of the decision points I think people make is also whether they should be placed on the wait list, whether they should apply for long-term care as they need more support. So having information not just focused on your prognosis and life expectancy, but the quality of life and where you want to receive care is also really important. So that is definitely one area that we're hoping to advance with this research.
Yeah, it's a dual sword, right? I think we're trying to improve care in institutional settings, but also in community settings. And I think one of the things that is really exciting, Amy, is that we're trying to keep up with the times, right? With data, and data is everywhere. And we're trying to incorporate real-time data from things like wearables. So people's iPhones, people's iWatches and fitness trackers and all these things that have incredible amounts of information about how agile or how frail you are. And we're trying to incorporate some of those inputs into Respect because we live in a data age and everywhere we look, there's data. And I think what's really essential about Respect is that we can't forget that it's not just about health data, but it's also about personal data and all that data that you collect yourself.
On behalf of our research team, we want to again thank AMS for supporting our research. And we want to thank the listener for joining us for this conversation today.
Yes, thank you, everyone. And both of us, again, are compassionate about improving end-of-life care and a real integral part of a good life lived. And I hope that you all can test out the Respect tool. It's online. And we would love it if you disseminate this across all your networks and all your friends and families. Thank you, everyone.
Thanks for joining us for this truly inspiring conversation. And a heartfelt thanks to Peter Tanuseputro and Amy Hsu for this incredible work. Don't forget to check out their Respect calculators at projectbiglife.ca. And don't forget to check out our next conversation on the AMS podcast, Good Tech, Compassionate Healthcare.
This podcast was produced by Michael McDonnell, music by Carlo Cruz.